Right, ladies and gentlemen, good morning. Today we're going to talk about bone scintigraphy, which is everybody's favorite topic. So we will be discussing conventional bone scans, MDP kinetics, trauma, infections, metabolism, and malignant disorders, as well as briefly touch upon sodium fluoride PET-CT. Basically what we wish to have but can't have. So conventional bone scintigraphy, it's a test that has been around for quite a while and withstood the test of time. It is still useful and we still use it on a daily basis. It's a test to detect active bone formation in the body. So this is not about detecting tumor, it's not about detecting a broken bone. This is about active bone formation in response to whatever process is going on. The images can be acquired with a planar or SPECT for improved uh, clinical resolution. So there are many indications. The two most common ones are detection of neoplastic disease, and the second one is detection of occult fractures. Occasionally, we suffer to try to detect osteomyelitis or reflex sympathetic dystrophy, but it usually doesn't quite work that well. But for tumors and fractures, it can work very, very well. Uh, Procedure itself, when reading the bone scans, it's extremely important to have the correct history. So let's say if it's a patient with suspected or diagnosed prostate cancer, but PSA is 5, I don't care what the bone scan is showing, you're not going to see any disease. Now, if it's somebody with a PSA of 100, you got to look hard to find the met. Same thing, it's important to understand the surgical history, the trauma history, the hardware, where, what, and how to correctly interpret it. In fact, Medicare actually now penalizes us when we interpret bone scans without comparison to cross sectional imaging, such as CT or MRI, and that's exactly to try to incentivize radiologists to increase the specificity, not just the sensitivity. All right, so this is how the scans look like. Uh, Anytime in rheology we can show a skeleton by itself, I think it's a huge plus. And with other tests than bone scan to demonstrate the bones of a skeleton. All right, so if you can answer these four basic questions, you can doze off or go get some sleep or have your morning coffee because you know everything. So you got to be able at the end of this lecture to describe physiologic distribution, tell me which organ gets the highest radiation, approximate the typical adult dose, and tell me the typical delays between injections and images. And I'm sure everybody in the audience already knows all of these questions. For those of you who have forgotten, we will try to clarify. So technetium-99m labeled radiopharmaceutical. In this case, it's bisphosphonate. The typical adult dose is 20 to 30 millicuries injected intravenously. If the patient is huge, we will increase the dose by up to 10%. For kids, the dosing is weight-based, and fortunately, we don't do this. The imaging is performed for bones 2 to 5 hours after the injection, and this is to allow the soft tissues to clear the tracer and the kidneys to excrete the tracer and the patient to pee it out. If we image earlier, we will see more soft tissues. The longer we wait, the better the tissue contrast gets, but then it becomes challenging. In theory, some places run it based on the renal function. In our case, it's just easier to do a standard delay for every single patient. For patients with abnormal renal function, sometimes doing 24-hour delays can help, but in my decade plus of experience, it really doesn't. In rare circumstances, we can attempt to use a pinhole collimator to amplify and increase the resolution, but again, that's exceedingly rare because you have to see the images before the patient leaves the department, which is challenging in any normal workflow. So these two images basically sum up what we use the bone scans for. The image on the left is a woman with breast cancer, and we see multiple foci of uptake in the ribs, spine, as well as left humors. So we know that this is extensive bone metastasis. The image on the right is a typical patient with prostate cancer. You can actually also see a Foley catheter bag on the floor, and we see lots of uptake in the spine, ribs, and bony pelvis consistent with metastatic disease. And these two images essentially illustrate the most common abnormal appearance of the bone scan. All right, this is another common disease that is always nice to diagnose in the bone scan. Who can tell me what this is? Well, I'm sure everybody got the right answer. This is Paget's, Paget's, and Paget's. And we see this convoluted uptake in the skull and pelvis. And the appearance is really characteristic. So once you see it once, you can't forget, and you'll be able to diagnose it confidently. What's going on in this case? Well, this is something we generally don't want to see. This is a child, as evidenced by markedly increased uptake in the growth plates, which is where the new bone is forming. And we can see focal increase right tibia showing uptake. In ideal circumstances, this needs to be done with MRI, not a bone scan, to avoid radiating the poor child. But in the past, this used to be pretty common, so this is probably tibial stress fracture. All right, what's going on in these images, and specifically, what are we doing to the bladder? So if we look at the whole body images, we can see that there is a lot of tracer activity in the bladder. Now, when it comes to these images, first we did some spot images, and then we drew a circle, or did we place something on the patient? So what we actually did is, since this patient can't empty the bladder, we put a bladder blocker. This is a sheet of lead between the bladder and the detector to actually decrease all of those counts hitting the detector. So this is not post-processing, this is actually a leaded blanket or something to prevent the counts. And on the image on the left, we're doing a time-based acquisition. The image on the right, we're blocking the bladder and doing count-based acquisitions to acquire some images of the pelvis. But as you can imagine, if this image was count-based acquisition, a lot of the counts would come from the bladder, and very few counts would come from the bones themselves. This is an illustration of SPECT versus planar images. On the planar images, we see this abnormal activity in the spine. However, when we see a whole mid-reconstruction, we see it much easier. And when we actually look at the slices, again, that abnormal activity in the spine is much easier to see in the SPECT. The downside, the techs don't like doing SPECT because it takes a lot of time because of the acquisitions. Patients start to move, patients don't like it, becomes a big challenge. This is a typical three-phase bone scan. This is how a lot of the scans used to be performed from the good old days before we had things like MRI and ultrasound or even CT. So the initial images are called the blood flow phase, and this is sort of replacement for angiography, I guess. And what we're looking for is not what is brighter at the end, but what lights up the first. The second phase is blood pull, that's obtained immediately after the flow phase is completed, and this is to compare uptake in the soft tissues. And lastly, the delayed images, and we can see the uptake in the bones themselves with clearance of the soft tissues. All right, since you guys are really smart, I'm not just going to ask you what disease this patient has, but I'm going to ask you in which city were the criteria written for the diagnosis of this disease. We'll count to 3. 1, 2, 3. And obviously, I'm sure all of you knew the answer. It's Budapest, and this is reflex sympathetic dystrophy with a characteristic periarticular uptake in the extremity. On an MRI, we will see periarticular edema. On the bone scan, we'll see this very, very characteristic uptake. And nothing on an X-ray. This is usually sequela of traumatic injury, and I used to think this is a nonsensical disease, but over the years now I've seen enough patients that some of which had relatively minor trauma, a small fracture, and subsequently would go on to develop this RSD, and the condition is pretty debilitating. All right, so this is fortunately a very rare application of a bone scan these days. We have an outside MRI that suggests presence of a MET or trauma in the spine, and the clinician asked us to do this three-phase bone scan to differentiate. So I'm going to ask you to look at it and tell me, is this A, MET, B, trauma, C, Paget's, or D, I should have gone into dermatology. And unfortunately, we really can't tell the difference all that much, because both MET and trauma will have increased tracer uptake. We can suggest it's probably not acute trauma because there is no increased blood flow, blood pull. But to be honest, looking at STIR images on the MR should be vastly more accurate. But this is how we used to do this in the long past. This really should be outlawed these days now that we have an MRI. All right, so trauma. Bone scans can be very helpful in detection of occult trauma, because sometimes the fracture is really not displaced on an X-ray or CT, although now on CT we have marrow imaging. Obviously MRI is preferred, but sometimes the patient cannot undergo MRI because of electronic implanted hardware. So let me show you some examples of applications of bone scan for detection of trauma. I'm sure by now everybody has seen the cause of the patient's problem, and this is a sacral insufficiency fracture, which you can see as sort of a half of an H sign in the back. All right, so this is a CT scan, and it does have a fracture, and I'm going to challenge everybody in the room to actually find it. To be honest, I don't think I would be able to detect this fracture, even in retrospect, but you guys are very smart. In fact, I'm going to help you. I'm going to give you a CAT scan that was performed a month earlier, which makes it sort of possible to detect it, although still I think it's really challenging. Now that everybody in the room has found it, I will show you a bone scan, and we see this real hot spot in the sternum, and obviously all of us now can easily identify this fracture that otherwise in general will go undetected. For fracture detections, most of them can be seen in 24 hours. By 3 days, really all of them should be noted, except in some elderly patients where it may take up to 5 days for the bone scan to show fracture. Now, compare that with MRI that will show edema in STIR images. I don't know how quickly, but probably much quicker than a bone scan. The fracture remodeling can go on for a while. This is a three-phase bone scan of bilateral hip prosthesis. And if we look at these images, we can see that the left hip prosthesis, which we can identify by this photopenic defect, has very little uptake around it. And this uptake the left hip was performed 4 years ago. Now, the right hip, you can see a lot of tracer uptake in both acetabulum and the femur, and this is a recent hip arthroplasty that was just performed 2 months ago. So now you can see how body deals with remodeling in a bone scan. So this is 2 months versus 4 years, so the activity gradually declines. All right, this is one of my favorite cases. This is in the collection. We can see that very sclerotic bones, yet one of the bones looks even more abnormal. So which disease does the patient have and what are we looking for? And this is the bone scan. So remarkably enough, there is not an diffusely increased tracer uptake throughout the bones despite the sclerosis in the sickle cell patient, yet an abnormal rib uptake indeed shows up quite clearly in the bone scan. So this patient turned out to have adenocarcinoma of unknown primary. At the point of the diagnosis, it was only involving the rib. I believe the patient went on to have radiation of the rib and did quite well until the tumor recurred with metastasis all over the place, as they usually do. For detection of malignancies, obviously bone scan has been around for a while. It's primarily used in prostate cancer and breast cancer because of its capacity to detect sclerotic bone lesions, although in breast cancer, I honestly prefer FDG PET scan anytime. In prostate cancer, a lot of the prostate cancers are not very FDG avid, so until the prostate membrane specific antigen PET agents come along, we will continue to use bone scan. The challenges occur when we do see a single lesion, particularly in the ribs, and also additional challenges in dealing with response assessment and flare phenomena. which we're going to review shortly. Again, going back to the pictures I already showed you, this is a typical picture of metastatic breast cancer and metastatic prostate cancer, which tends to be pretty straightforward. Well, let me show you a different situation. How many of you have found abnormality on this scan already? When you look at the spine and ribs, it looks pretty reasonable, but once we look at the hip, we can see that there is some abnormal uptake. Now, when we look at the CAT scan, we can see awful lytic lesions causing pathologic fractures. So the amount of uptake on the bone scan seems to significantly underestimate the degree of the problem, because we're not detecting a tumor, we're detecting remodeling in response to pathologic fracture caused by this aggressive T-cell lymphoma. And when we compare it to FDG PET scan, we can see tons of FDG uptake, very intensely FDG avid tumor, and this is much easier to see on a PET scan. And we can also see pathologic fracture, whereas just by looking at the bone scan, we would significantly underestimate severity of disease. So bone scans do not work very well for lytic lesions. All right, well, let's look at this case. This was a big diagnostic challenge, but eventually we did figure it out. So if we look at the scan, what do we see? Well, we see this FDG avid uptake of tracer in one of the left anterior ribs. So is this a trauma or is this a MET? If we look at the literature, it said that with a single rib lesion, it only has about 11% chance of being a MET. If we have two lesions, it's about 35. When we get to 5 new lesions, it's about 100%. So with a single lesion, is that a MET or not? Well, fortunately, as required by Medicare, we compare to other cross-sectional images. And in addition to that single rib lesion, we actually also see innumerable new lung nodules, so we can confidently pronounce it to be the other 10%. So this is a progression of metastatic prostate cancer. Although, to be entirely honest, once we've come to this visualization and start to really carefully window our images, we can see that it's not just a single, not just a single lesion in the spine, in the rib. We can actually find some abnormal tracer activity in the spine, but this illustrates the challenges involved. All right, this is another example. This is a tumor that was primarily involving the soft tissues and was secondarily infiltrating posterior elements, and it also does show up on the bone scan, but again, it's hard to imagine looking at these two spots the actual extent of the tumor. This is a really nice chart that from a paper that talked about response assessment using bone scans. When the chart looks that complicated, you can clearly tell that bone scans do not work for assessment of tumor. So in this particular case, it seems to be relatively straightforward. We have a few bone lesions. On the follow-up a year later, we have more, and then 2 years later, we have more. So clearly, this is a tumor that's progressing. This is the opposite example. This is a patient with widely metastatic prostate cancer that was treated with radium-223. So pre-treatment, we can see lots and lots of bone metastases, and after treatment, we can actually see decreasing intensity of tracer uptake. They didn't go entirely away, but we can see things are moving in the right direction. So there is some reasonable applications for response assessment. What we can see on the CT is pre-treatment, we have really sclerotic lesions and somewhat sclerotic lesions, and post-treatment, what was slightly sclerotic is becoming more sclerotic as it's healing, and paradoxically, we can actually see decreasing tracer uptake despite increasing sclerosis on CT scan. On the same patient, MRI confirms absence of restricted diffusion in this lesion, so consistent with treatment response. So again, our colleagues from Europe suggested in the paper a variety of tracers that can or cannot be used in assessing treatment response. Once you have that many pluses on the chart, again, you know nothing's going to work. So one of the bigger challenges in assessing treatment response with cancer is flare phenomena. And what happens after we give therapy and tumor dies, the body is going to respond and will try to heal it up. And this is typically seen from a few weeks to 3 months after therapy, but by 6 months that flare should go away. And this is an example of a lesion at baseline that gets brighter at 3 months after therapy, yet at 6 months gets darker. So 3 months increase in uptake was flare phenomenon, and then the tracer activity, trace intensity decreases. But yet we're still not sure, is this complete response, is this partial response? Bone scans don't really work very well for that purpose. This is an example of a patient that has lots of lesions pre-therapy in the bone scan, and 2 weeks later after therapy has far more lesions. Yet when we compare the PET scans pre-therapy and post-therapy, clearly the patient is responding, and this increased tracer uptake on the post-therapy scan is flare phenomena, and this is why we try to avoid imaging with bone scan less than 3 months after, less than 6 months after giving therapy. Soft tissues, it's really important to pay attention to soft tissues, to look at the kidneys and the tracer excretion. All right, so what's wrong with this scan? I'm sure you were able to quickly figure it out. The patient has no kidneys. We don't see any renal uptake, we don't see any bladder uptake, and the tracer is simply sticking around in the soft tissues. And if you look at the legs, we can't even see the bones. And this is why in a typical patient, we try to wait for 3 to 6 hours for the tracer to be cleared by the kidneys. In this case, it's not possible. So our best bet is to try to do some delays to see the skeleton. Okay, what about this case? Who can tell me the answer of what is going on? I love this case. Well, this is a horseshoe kidney. We can see bladder activity, so there has to be a kidney somewhere in there. And in the posterior image, we don't see it in a typical location. And in the anterior image, we can see a nice horseshoe kidney where it's supposed to be found. Okay, who can tell me what is going on in this particular case? Well, we really don't see either kidneys, we don't see bladder, we don't see soft tissues. So this is a super scan. This pattern is produced by either tumor diffusely involving the entire skeleton, particularly characteristic for prostate cancer, or hyperparathyroidism driving bone metabolism everywhere in the body. So in this case, this was tumor. Okay, what about this case? Who can tell me what's going on? All right, I'm sure all of you have figured it out that one of the kidneys is abnormal. So is it the left or is it the right? Well, since the images are delayed, the right kidney is normal because we only see tracer activity a little bit in the collecting system. But on the left, we see the entire kidney, which should not be the case. And when we look at the CT images, we see hydronephrosis and we see ureteral obstruction. What about this case? This is one of the few favorites for nuclear medicine people, using bone scan for looking not at the bones and thinking that this is important, but that's what we like to do. And in this particular case, we see malignant pleural effusion, so we see more uptake in the soft tissues of left hemithorax than we should. What about this case? Can anyone figure out what's going on? This is the most gross misuse of bone scan possible. We're going to have to rely on SPECT images to try to localize where that spot is. And if we look at the SPECT, we can figure out that this is actually myocardial infarction, and we're seeing a tracer uptake in the heart. The same will be true for strokes. If we do a bone scan after a stroke, we will see tracer deposition in the brain because of calcifications in the area of stroke. All right, what about this case? Can anyone figure out what's going on? And this was a hepatic tumor, and we can see abnormal uptake adjacent to the kidney. So this is tumor in the liver. Sources of error for bone scans, well, typically they have to do with injection artifacts, extravasations, not being aware of the implants, not being aware of the trauma. The soft tissues can become pretty confusing. So this is where we have to really compare to CT, MR, X-rays, previous bone scans, be familiar with the history to avoid misinterpretation. So what happened in this case? Well, as it turned out, the patient had an FDG injection for PET scan earlier this morning and then came to receive their bone scan, and as you can see, did not quite work with high energy FDG photons causing all sorts of havoc. What about this scan? Can anyone tell me what's wrong? Well, it's not a bone scan, it's a gallium scan. All right. With that, since that scan was looking at us accusingly, we'll switch to the sodium fluoride PET. And what it is, it's essentially a same bone scan agent that works with a PET scanner. It was originally improved in '72, sort of died out, and then about a decade ago there was a shortage of technetium for bone scans, so there was a little bit of a resurgence, but again it rapidly died down because of expenses. And this is the information about the typical doses and organs receiving the greatest radiation, and obviously because of the urinary excretion it ends up being bladder, which is pretty typical. In terms of radiation, a typical effective dose is 10 millisieverts, which is quite a bit higher than the conventional bone scan, but the images make it worth it. So these are examples side to side of image on the left is the typical bone scan, and image on the right is a sodium fluoride PET. And you don't have to be an expert to say that this image is much better than this image. Again, remember, sodium fluoride PET is not an FDG PET, it's only bone imaging agent. So we can see there's a huge liver on an FDG scan. Something will show up in the sodium fluoride PET because of calcifications and necrosis, but it's not designed for soft tissues, it's a bone agent only. So in studies that have compared conventional bone scan to sodium fluoride PET, sodium fluoride certainly came out on top, and it was much better. And again, not surprising because a PET agent will produce much prettier pictures. At the very least, inherently, you will have built-in attenuation corrected in CT images for comparison. Yet when we compare FDG with sodium fluoride versus technetium MDP in evaluation of lung cancer, really, FDG PET is more than sufficient, and the other two agents and scans are completely unnecessary and realistically do not add anything. All right, so in summary, bone scan is bone formation. We generally should wait at least 3 hours after injection to get some images. Pay attention to soft tissues and renal function. For fractures, at least a day, best to wait 3 days, and takes generally up to 2 years to resolve after the fracture heals. Detection of metastases is highly tumor dependent. We primarily use it for prostate and breast cancer, and we need blastic metastases. Otherwise, we're detecting tumor response to bone response to pathologic fracture. Response assessment with bone scans is very challenging. We really should wait at least 3 months or preferably 6 months to avoid the flare phenomena. Sodium fluoride PET, it's a much better version of a bone scan at the cost of higher radiation, but in most circumstances an FDG PET is better. All right, thank you very much. You have survived.